Hello dear guys, we'll start our next set of lectures about endocrine system. It will be pathological physiology, but it's mixed up with pathological anatomy as always, so that's why it doesn't matter it's physiology or pathological anatomy of endocrine system. As you already have the anatomy and physiology of endocrine system and also histology, and based on it, so now will be followed explanation. So today we'll discuss the pituitary gland and thyroid gland pathology, and if we'll have time, so we'll discuss a little bit about parathyroid glands. In next class we'll discuss, in next lecture we'll discuss adrenal cortex, adrenal medulla, and one of pathology condition which is known as multiple endocrine neoplasia syndromes. So, and endocrine pancreas, of course, and diabetes mellitus we'll discuss. First of all, let's remind you what's the pituitary gland. Pituitary gland is a mixed gland, so which is mixedly formed from so it's endocrine gland. Of course, it's a totally endocrine gland, but it's made as a mixture between ectoderm and neuroectoderm. So just convenient endoderm and neuroectoderm, and I explained you embryological composition of it, and it is also composed of two types of portions, neuro hypophysis and adena hypophysis. Yeah, and the pituitary gland is composed of this, and based on the cells which are present there, we will discuss different syndromes. So, anterior pituitary adenic hypophysis produces trophic hormones. So yeah, as we discussed, trophic hormones, so which cause the enlargement of this tumor, enlargement of activity of other hormones. So this is a chief of hormone, yeah, so which causes activation of other hormones. So and this is adena hypophysis, and posterior portion, which is usually named as neurohypophysis, produces vasopressin and also oxytocin. Okay, vasopressin, another name is antidiuretic hormone, and we will discuss about this also right now. So once again, yeah, histologically, you remember that adena hypophysis contains chromophilic and chromophilic and achromatic cells. Chromophilic present with basophilic cytoplasm, and eosinophilic cytoplasm. Achromatics, they present without any color. So let's talk about syndromes which are present. It's hyperpituitarism, hypopituitarism, local mass effects. This is three main effects which are caused by pituitary gland tumors. Of course, adena hypophysis. We'll first of all discuss adena hypophysis. Hyperpituitarism. Hyperpituitarism, so it means overproduction of some hormone made by pituitary gland. And usually all these effects are measured by anterior pituitary adenoma. Adenoma, so I remind you definitions here. Adenoma means tumor of gland, so benign tumor of gland. And usually pituitary gland is affected by benign tumors. And in this hyperpituitarism with adenoma, and producing adenoma is made by usually chromophilic cells, which are present in tissue, guys, don't late, so 15 minutes passed. Okay, symptoms and signs of hyperpituitarism, we will continue discussion of this, but mainly we can say just imagine one trophic hormone is overproduced. So what is the reflex to this? Of course, over secretion of other hormones which they are responsible for. For example, ACTH overproduction, adrenocorticotropic hormone overproduction, leads to formation of more cortisol and hydrocortisone. So this is our and this works in this way. And somatotropin, for example, causing the formation, causing increasing of body high, and mass is also overproduced. and it causes gigantism, yeah, disorder. Okay, I will discuss it in details later. Then hypopituitarism. Hypopituitarism, it's when function of pituitary gland is decreased. So it also might be related to tumor, but achromatic cells tumor. For example, you remember we have achromatic cells which doesn't collect any color. It doesn't, and we have have no confirmed function of the cells, and that's why sometimes it leads to hypopituitarism. It's very rare, but much more commonly we have a destructive process in hypophysis, in pituitary gland. It's like ischemic injury, surgery, radiation. So it is shown here. Inflammatory reactions, autoimmune usually. Then and secondarily we have non-functional pituitary adenomas may encroach upon the destroy the normal anterior pituitary, causing hypopituitarism. You see, secondary another tumor, tumor of non-producing cells, causing destruction of pituitary gland, as I said in the beginning. And then a last group of symptoms, they are made by local mass effects. Local mass effects, they are here I want to remind you the location of this pituitary gland. Pituitary gland is localized in a cella turcica. So maybe here it will be shown. No, diagram is not shown. Sorry. So let's talk about anterior pituitary tumors. So no, wait a bit. Local mass effects.
Actually, that thing is not 100%.
Yeah. Wait a minute. We'll discuss it after lecture. Okay. Local mass effect. Location of pituitary gland is directly in cella turcica. Cella turcica around the bones. Yeah. And when it grows goes in upper position out of cella turcica. If you remember structure of sphenoid bone. So you remember cella turcica, and it's like cane. Yeah, so no, not cane. It's like little invagination of the skull, yeah, where it's located. And when it grows outside. And what is located above the pituitary gland? Might be you remember it's a chiasma. It's optic chiasma. So optic chiasma, it's a site where optic nerves, they intermix with their nerve fibers. So when 20% of one of left goes to right, and 20% of right goes to left, yeah, of this optic nerve. And you understand. So if tumor grows and it little suppress, little push on the push of these nerves, it leads to some lesions. Yeah, lesion in normal transmission of the signal, and of course it will be different vision problems. So you'll better discuss it in neurology. So they'll explain you different divisions. So it might be side portions of vision are empty, and you can see only in the center, or opposite, centrally you can see it, but you see it only in peripheral vision. Might be one eye doesn't, the one side doesn't is not visible, or left side is not visible. So it depends on location of this tumor and quality of this growth. And that's more typical visual fields called bitemporal hemianopsia. So it's half of vision pole is not visible, like bitemporal hemianopsia. So most commonly is this one. So when lateral parts of the vision pole is not visible. Okay, cranial nerves can result in cranial nerve palsy, on occasion acute hemorrhage into pituitary neoplasm associated with the rapid enlargement of the lesion and loss of consciousness, a situation termed pituitary apoplexy. So this pituitary apoplexy also sometimes happening, so due to increased growth, increased blood intake, blood supplement of this tumor, so some capillaries might be ruptured due to mass effect. And of course it might lead to apoplexy. Apoplexy, it's bleeding inside the tissue. bleeding directly inside the parenchyma of this tissue. It leads to increasing of size, and of course it will be look like a stroke. And this is a neurosurgical emergency to save the patient's brain. Of course, we have to remove this pituitary gland during the surgery. Then anterior pituitary tumors. Let's talk about details of it. Pituitary adenomas. Most commonly they are adenomas. They are classified on the basis of hormones produced by the neoplastic cells. First of all, they might be TSH producing tumor, prolactin producing tumor, ACTH producing tumor, growth hormone producing tumor, follicular stimulation hormone producing tumor, and luteinizing hormone producing tumor. You remember that these hormones are under control of releasing hormones, thyrotropin releasing hormones, prolactin, PIF, don't remember actually. So here is written, let's check it out, or dopamine. Prolactin inhibitory factor. It's opposite. Prolactin is negatively, negatively controlled by prolactin inhibitor factor. CRH, it's corticotropin releasing hormone, so it's positive feedback. Growth hormone releasing hormone and growth inhibitory hormone, so somatostatin and releasing hormone of growth hormone. So they cause a positive and negative effect to the growth hormone of the anterior portion of pituitary gland. And gonadotropin releasing hormone, so produce FSH and LH. So I remind you, so all these hormones of this site, they're produced in hypothalamus, and it gives through the infundibulum, it descends into the pituitary gland and into the anterior portion of pituitary gland. It gives like order for them to produce this tumor, to produce this hormone. Sorry. Pituitary adenoma can be functionally hormone producing, can be functional and non-functioning. So functional means they produce hormones, and non-functioning they are non-producing, hormone non-producing. Both of them are composed of single cell type, so because you remember the mechanism of cancerogenesis or tumor, any tumor is produced usually from one cell or from one group of cells. So that's why these adenomas are produced, they usually contain only one cell type. And of course, if you have one cell type like ACTH producing cells, they will produce only ACTH, no other hormones. Pituitary adenomas are designated as microadenomas as they are less than 1 centimeter in diameter, and macroadenomas if they exceed 1 centimeter in diameter. So, what's the point? So usually, if we have microadenomas and we have a very moderate effects of this tumor, so we don't do the surgery. Microadenomas cannot be treatable with surgical methodics. Might be in future it will be improved, but as now microadenomas are not released. But macroadenomas should be removed. And what's the difference? Yeah, in case of microadenomas, usually when we mentioned it only in that case if it produces a lot of hormones. When we suggested this, so microadenomas are visible. So usually found only in microadenomas. They are usually hormone secreting gland. But macroadenomas, if they exceed 1 centimeter, and we mentioned this, so it means it's usually hormone non-producing tumor. Because both of these tumors growing very slow, but if we mention it, so microadenomas can be mentioned by or hyperpituitarism, or usually by hyperpituitarism syndromes, but in case of macroadenomas, we usually mention them by local mass effects. Yeah. So that's why we can we usually divide this like microadenoma and macroadenoma. Yeah, it's here. It's said it's only in later stage. It's foundable. Then pathogenesis. Pathogenesis is very complicated. So it's a G protein mutation are one of the most common genomic alterations due to adenomas. So mechanism of this, we approximately discussed it in cancer topic. Yeah, so how it's divided, how it's all about ligand. It's a ligand for gonadotropin, releasing hormone, TSH, PTH. So all of them are all of them are causing the effect of this receptor, and abnormal effect of this G protein. So it leads to proliferation of these cells. Okay, so this is pathology. Actually, other mutations you shouldn't learn. So all this we discussed about hallmarks of cancer, especially when occurred the malignant tumors. So they include this TP53 mutations, RB gene mutation, retinoblastoma gene, yeah, RAS mutation, RAS oncogene, cyclin D mutation. So all of this we discussed in previous semester in cancerogenesis, so that's why no need to know it. So here you see, you approximately understand the normal anatomy of brain. So here you see, of course, it's a very great mass which you see suppress the normal ventricles, structure of brain also diminished, yeah, so also smashed. Of course, it gives very some local effect. So this is obviously non-producing tumor, because just imagine this mass starts to produce hormones. Of course, patient would mention it even in a smaller tumor. So, and what is this? Yeah. So what is this small reddish-like patches? The smallish reddish patches, they are bleedings. They are little hemorrhages inside the tumor. So due to extreme growth of this tumor, you remember production of VEGF goes, vascular endothelial growth factor, TGF, which causes the angiogenesis here inside the tumor is happening. And these gentle tumors can be ruptured, and it causes a little bleeding. So these small areas of apoplexy of this tumor, but it's not urgent to remove it. So and this is adenomas, is general features of adenomas. So let's talk about functional adenomas and hyperpituitarism. So different types of hyperpituitarism. Lactotroph adenomas. So it's a prolactin secreting adenoma. So by which we mentioned usually by increased level of prolactin. So what is the battle for prolactin? So actually you might remember. So prolactin is responsible for milk secretion in females. But actually, this prolactin has a side effect. It depresses the normal gonadogenesis. So it depresses females' ovulation, and it depresses males' spermatogenesis. So we don't understand what's the evolutionary role of prolactin effect on males, but on females it is very visible. Yeah. Because when a female feeds the baby, actively feeds the baby, of course it's not necessary to be pregnant again. Yeah, and it's like natural contraception, but it is not very well contraception. Yeah, because you can listen different people and you can hear about numerous cases when during the feeding, during baby feeding, breastfeeding of the baby, so they get pregnant during the during sexual intercourse, and it was very great surprise for them. Yeah, and because there are no menses, yeah, amenorrhea happened there, and they didn't mention menstruations because there were no menstruations, and they get pregnant in a row. And it's that's why it's very recommended after the delivery, after the birth of baby, so to have sexual intercourse only with barrier contraceptives, so with a condom. Yeah, so because pregnancy directly after one birth is not so convenient. Yeah. Okay. And his hyperprolactinemia usually caused by microadenomas. And usually patients with this pathology go to urologist or gynecologist, and they ask about so they come to because of infertility. And yeah, secondary to this, they complain about libido, also might be galactorrhea, so females, or and very commonly amenorrhea or dysmenorrhea. So this dysmenorrhea or amenorrhea, so dysmenorrhea when improper leading of menstrual cycle. Amenorrhea is absence of menstrual cycles. So that's why, and it might be caused by prolactin hypersecretion. Okay, that's why no other obvious effects of prolactin we can see. So this libido changes, they are not typical. So it might be 20% of all patients with this tumor. So you can see decreased libido. Infertility are much more common. So a lot of patients who have microadenoma of prolactin, so they have no complaints, no any other consequences. So that's why we treat only in case of infertility usually, or might be in severe libido decrease, loss of libido, severe loss of libido. Only in that case we try to treat it, because in other case treatment is not necessary. We have some hormones which decrease the secretion of prolactin. Then somatotroph adenomas. Let's talk about somatotroph adenomas. Somatotroph adenomas, they are so somatotrophic hormone. We understand it. It's a growth hormone, or another name, growth hormone. It's produced by somatotroph adenomas, and we can see it, and you can imagine. Yeah. So if growth hormone is produced from childhood, we would see patient which looks like. Suddenly I didn't take this photo, so you can check gigantism. So gigantism is a disorder which is typically found. Gigantism. It's a very large height of the person. So it's all the world records you see that in Guinness records. Yes, so you can see that. Largest person of the world, largest person of every country, they have this microtumor, microadenoma of this growth hormone cells. Also, it's anabolic hormone, so it leads to gain of weight, not only height but also weight, and they have specific, very specific features. With expression. So later, yeah, I'll Google this picture right now for you and show it to you. And then we have another syndrome known as acromegaly. Acromegaly, it's growth happening in growth plates. So gigantism, if gigantism goes in from childhood, so it moderately increases the size of the body. But in acromegaly, so it affects only a remnant parts of cartilages. So here you see the difference. In gigantism, we have our bones are still not formed yet. And in epiphysis, you know, this epiphyseal plate we have, and in epiphyseal plate growth is continued, right? And that's why entire body proportionally increased in size. But in case of acromegaly, only those portions with the cartilages will grow independently from other parts. So let's Google it. I will show you another picture. So take a look. This is typical acromegalic face. This typical acromegalic face. So it's not well visible, I guess. This is gigantism. So reminds Shrek, yeah, from the So actually Shrek is made up of from the face expression of these males and females with the gigantism and acromegaly. So okay, not good, no good examples. Just let's talk about gigantism. You see all these pictures of extremely large persons. They are examples of gigantism. Let's talk about acromegaly. This face expression is typical. Okay, let's take a look. You see, extreme large cheekbone is very prominent, very large mandibular, very massive mandibular, very massive eyebrows. So in other portions of, yeah, in the hands you see very thick fingers. Because of what? Because cartilages are still present there, because still here we have cartilaginous portions of the joints, and because of them growth of these fingers going faster than in a usual person. So that's this comparison of fingers. And you see acromegaly happens after elderhood. So these examples. So this is acromegaly. So actually we have a mixed types of acromegaly and gigantism. So if a person from childhood has gigantism, so and continue and production of growth hormone is continued in elder period, so it leads to acromegalic features of this person too. Okay. Let me show another picture. So this is somatroph adenomas. So let's talk about corticotroph adenomas. Corticotroph adenomas, they are also known as ACTH producing tumors. ACTH producing tumors, they are causing Cushing syndrome. This Cushing syndrome, so by Cushing syndrome or Cushing-Goy syndrome, we name the overproduction of glucocorticoids, and later in adrenal gland pathology we will discuss this. What is the Cushing syndrome in more details? But in beginning, so we can say that Harvey Cushing described this disorder, and by this we can see that ACTH is overproduced. By ACTH produce influence to the cortex of adrenal glands. Cortex of adrenal glands produce cortisone and hydrocortisol, and these hormones start affecting all the metabolism of our body. Both of these hormones are catabolic, and they cause the gluconeogenesis from our proteins, and they depress the normal protein production. And that's why, and a lot of other effects causing the obesity also, very specific type of obesity. And this, okay, more about it we'll discuss in adrenal gland pathology. So usually pathogenesis of this is Nelson syndrome, so which is a loss of inhibitory effect of adrenal corticosteroids on pre-existing corticotroph microadenoma. So normally we have negative feedback. Yeah? Yes? Question? Okay, it's Nelson syndrome, so when we have no negative feedback to the corticosteroids. So normally corticosteroids has very prominent feedback form. So and that's why when you manage the treatment by corticosteroids, so it's very common drug which is used. So you manage it at morning and at lunchtime, but not in evening, because in evening the most pronounced production of glucocorticoids in our body happens. And if you manage glucocorticoids in evening period, so it leads to this negative feedback, and it suppresses the normal activity, normal expression of glucocorticoids in the body. So that's why very important to manage these drugs in mornings and lunches, not before 12 o'clock, not later than 12 o'clock. So other anterior pituitary neoplasms. So we have gonadotroph-adenomas. So they are very rare, and they produce luteinizing hormones, follicle stimulation hormones. They act on reproductive organs. Neoplastic cells usually demonstrate immunoreactivity for the common gonadotropin alpha subunit and the specific beta FSH and beta LH, beta follicle stimulation hormone and beta luteinizing hormone subunits. So they are okay, you understand. So they influence on our on the gonads, and of course it leads to infertility. Yeah, tyrotrophs, TSH producing tumors. They are very rare adenoma of pituitary gland. A very rare case, but sometimes it's also happening. It leads to increased thyroid gland production, but it's a very rare condition. We have much more common Graves' disease instead of hypersecretion of pituitary gland. The non-functioning pituitary adenomas are heterogeneous group that constitutes 25-30% of all pituitary tumors. So as I said before, they are mentioned only in larger size, and we do examination of these tumors only if they became very large, and we can follow the mass effect. We can observe the mass effect of this tumor on the brain and on the optic nerves. And then pituitary carcinomas are exceedingly rare. So that's, please remember, they are very rare. That's why in case of a tumor you found in a pituitary gland, you can claim that almost always you'll be right that it's not cancer. It can be explained by this way, so that tumors, why we have tumors? Because it's epithelial tissue derived from ectoderm. So ectoderm is for ectoderm is very typical formation of tumors, same as endoderm. But this ectoderm, why ectoderm is more typically happens the tumor? Because they are dividing continuously. But ectoderm on the skin and oral cavity, for example, they are always in constant interaction with the external environment. But pituitary gland, made of the same tissue, but appeared very deep in the brain. They have no interaction, any noxious stimuli from the environment. Of course, it's pretty safe for cancerogenesis, but still some genetic lesions, some hallmarks of tumor are found there. Okay. Summary. More commonly we have prolactinomas, so which leads to, first of all, infertility, and in females especially cause amenorrhea and galactorrhea. Growth hormone in child period causes gigantism, in adult causes acromegaly, and they impair glucose tolerance and diabetes mellitus. Of course, diabetes mellitus is secondarily formed here, but we'll discuss the mechanism of this. It's a little more complicated than just direct action of this growth hormone. Corticotroph cell adenomas, also very typical, causing the Cushing syndrome, hyperpigmentation. This hyperpituitarism might be caused by tumors and other mass lesions which suppress the activity of pituitary gland. Ischemic necrosis of the anterior pituitary. It's known as the Sheehan syndrome. So it's necrosis of anterior pituitary. So it's usually happens during the pregnancy. So usually due to okay, so we can read. And iatrogenic causes. It's due to surgery which is made on the tumor. So when for example, we try to remove one tumor, but we remove entire pituitary gland. Yeah, and that's why. So by surgery, or might be during the radiation or treatment of any tumor in pituitary gland, we can destroy and healthy part of the pituitary gland. Okay, let's talk about posterior pituitary syndromes. So, and these two hormones we should discuss. They are antidiuretic hormone and oxytocin. Antidiuretic hormone, it's a non-peptide, so this is typical hormone synthesized in the supraoptic nucleus. Yeah, you see it's produced in supraoptic nucleus, but it sends to the posterior pituitary gland and released by posterior pituitary gland. So that's why keep in mind that posterior pituitary gland is not producing these hormones, but it's just sends these hormones into the blood. So function of oxytocin we discussed is the construction of smooth muscles of uterus. And let's talk about most important disorder we discussed before. It's ADH deficiency. ADH deficiency, which is much more commonly named as diabetes insipidus. Diabetes insipidus, it's a disorder which is by symptoms it very resembles the diabetes mellitus. So which main three symptoms we have in diabetes mellitus? Maybe someone heard about it. It's first polyphagia, a lot of intake of a lot of water, and constant thirst. Secondly, it's polyuria, yeah, and polyuria, and which leads to polyphagia, polyuria, and dry mouth. Yeah, so polyuria, so a lot of water is released, but instead of in diabetes mellitus, concentration of urine will be increased due to increased glucose level in urea. So here it will be opposite. In this case, polyuria will be diluted water. So so we see concentrative function of kidneys is shut down due to inability for normal reabsorption. So it leads to inability of the kidney to resorb water properly from the urine. Of course, it leads to formation of imbalance between ions and water exchange. So, what can we say about it? Yeah, just keep in mind that excessive water intake and excessive water loss might be related to ADH deficiency. Inappropriate ADH secretion is typically associated with ADH excess, which causes resorption of excessive amounts of free water, resulting in hyponatremia. So this syndrome of inappropriate ADH includes the secretion of ectopic ADH by malignant neoplasms, and we discussed it in your reports with some of groups. They are produced by small cell carcinomas. So that's why sometimes retain of water with hyponatremia syndromes might be related with not only lack of normal fluid amount and salt in disbalance, but also might be caused by cancer, small cell cancer of the lungs, because it's very rarely present initially in pituitary gland. Okay, now let's talk about thyroid gland. So thyroid gland is consists of two bulky lateral lobes, blah blah blah, anatomy and physiology you know. They are under control of TSH, thyroid stimulation hormone, or another name thyrotropin, and thyrotropin is under control of thyrotropin releasing hormone. So you see, in binding of TSH on the thyroid gland, we have, you remember, we have two types of cells, two main types of cells in thyroid gland. They are follicular cells and interstitial cells. And follicular cells, or parafollicular cells, yeah, follicular cells, they are typically producing T3 and T4, and on the surface of these cells we have TSH receptors, and TSH causing the proliferation and enlargement of the cells, and it's of course associated with this stimulatory G protein, and this G protein cause the activation of CMP. So what is CMP we discussed. Then thyroid follicular epithelial cells convert thyroglobulin into thyroxine and lesser amounts of triiodtyramine. And this T3 and T4, they are exactly hormones, and function of these hormones we discussed, and in physiology and histology we discussed it. So let's talk about pathology of this. Hyperthyroidism. So hyperthyroidism, whatever is the cause of it, hyperthyroidism is when we have increased levels of T3 and T4, so elevated levels of these two hormones. How it works? These hormones, so you see, as it's visible here, T3 and T4, they have effect on gene expression. We have thyroid hormone receptor inside the nucleus. With T3 and T4, they are penetrable through the cell membrane, and they have a receptor. We used to think that receptor is present on the surface of cell membrane, but receptors for thyroid hormones, they are present in a nucleus, and it's a floating protein. An activation of this thyroid hormone receptor in a nucleus, it causes the activation of target gene. And target genes of the which are usually stimulated by T3 and T4, they cause the increased metabolic rate. They increasing the metabolic rate, causing the rearrangement of the cell to produce more, to lose more energy without production of ATP. Instead of production of ATP, it loses energy to produce heat energy. So this T3 and T4 is produced like in aim to produce more heat by the body, less effectively without proper energy, ATP energy production. So that you should remember. And which symptoms of hyperthyroidism we can mention? Which symptoms we can find? So it's a skin or of terotoxic individuals tend to be soft, warm, and flushed because of increased blood flow and peripheral vasodilation to increase heat loss. So you see, as heat more produced, so we need to lose this heat, right? And that's why skin became very reddish. Heat intolerance and excessive sweating are common. So because so you know that normally heat is produced by muscles in our body, but now with large levels of T3 and T4, all over all the body is producing heat, and additional increasing of temperature, so by muscle activity. So it leads to increased temperature of entire body, and heat is lost. And also very common weight loss. Weight loss even with increased appetite, because we need to gain more energy, we need to gain more feeding products, yeah, but weight loss will be there. So because of what? Because again, ineffective use of the energy, gained energy. Instead of saving all this energy, we just lose it in the way of temperature. Then gastrointestinal. Which other symptoms? Gastrointestinal symptoms. Its stimulation of the gut results in rapid transit time, hypermotility. So what is it? It leads to malabsorption and steatorrhea. So in easy words, it will be named as diarrhea. So but it's not typical diarrhea. Okay, 1 minute. So gastrointestinal, so you see, it's malabsorption and steatorrhea just because of hypermobility of thyroid gland, hypermobility of digestive tract due to thyroid gland production, and cardiac effects. So most commonly we mention it by cardiac effects. It leads to palpitations, tachycardia, and increased blood pressure. Blood pressure will be increased along with tachycardia, and if you see patient with the tachycardia and increased blood pressure, so you can suspect this thyroid gland pathology too. So which diseases are causing it? So it might be diffuse hyperplasia of thyroid associated with Graves' disease. So what is a Graves' disease? So we'll discuss today. Hyperfunctioning multinodular goiter, So we have goiter, yeah, so multinodular goiter, and hyperfunctional adenoma of the thyroid. So it's much rare. So what is a toxic adenoma of the thyroid? Let's talk about them. Yeah, other effects which are happen due to hyperthyroidism. They are neuromuscular effect, frequently experienced nervousness, tremor, irritability, sympathetic. It causes activation of sympathetic activity. That's why thyroid gland overproduction. Thyroid gland overproduction leads to tremor and irritability. Then ocular changes. So ocular changes. So here we see. We because of so usually it happens in Graves' disease because of autoimmune lesion of periorbital tissue, and due to periorbital tissue swelling, so it leads to rolling out of eyes, out of eyes. So it's a very typical symptom. Then it's and also, yeah, of course, it's staring gaze and lead lag are present because of sympathetic overstimulation of superior tarsal muscle, but it's a less common effect. So usually it's related to thyroid ophthalmopathy is due to Graves' disease. Then thyroid storm. Thyroid storm, it happens in abrupt onset, so usually due to cessation of the thyroid gland during the surgery. So during the surgery, we can all this collected T3 and T4 in a tumor, so it's released interstitially into the blood in one moment, and leads to crisis. It leads to increased effects of thyroid gland in one moment. So it might be the cause of death. It's a medical emergency. Significant number of untreated patients die of cardiac arrhythmias, as I said before. It causes arrhythmia. Then apathetic hyperthyroidism refers to thyrotoxicosis occurring in older adults, in whom the typical feature of thyroid hormone excess often are blunted. So we don't understand the cause of it, but it is one of syndromes. Then let's talk about much more, not more interesting, but also very common pathology is hypothyroidism. It's structural, functional derangements that interfere with thyroid hormone production. So somehow thyroid gland stops producing normal amount of T3 and T4. It's caused by genetic defects, endemic deficiency of dietary iodine. You know what's it's goiter disease. Iodine deficiency, goiter disease, autoimmune thyroid disease. It's Hashimoto thyroiditis, actually, iatrogenic hypothyroidism. So due to incision or radiation-induced therapy, and from childhood, if we have deficiency of iodine or T3 and T4 deficiency, it leads to cretinism. It's hypothyroidism from childhood, from infancy to early childhood. It leads to decreased mental abilities of this patient, and that's why even now we have a description of cretins, so like coarse word for mentally disabled persons, and cretinism is derived from decreased thyroid level. Genetic defects, you understand, so congenitally it's very rare type of lesion. Here that's because if we have so severe damage of genes, so patient will not survive. So that's why this is a very rare condition. The endemic deficiency of dietary iodine is very typical. So for example, in our country, in mountain regions, and especially present in the center of the largest continent of the world. So of course, iodine cannot reach this area. Iodine, so very rarely with musa can get into our places, and that's why iodine is deficient in our region, and for that reason we eat only. So we use in food only salt with iodinated salt, with iodine inside, and by this we just cover iodine level in the population. Okay, autoimmune. Oh yes.
Sir, some student wants, sir, they ask to, sir, they allow, sir, allow us.
1 hour passed from the beginning of lecture, so no, they are not allowed. So autoimmune thyroid disease is a common cause of hypothyroidism in regions of the world where iodine is supplemented in dietary salt products. So this is autoimmune disorder which causes the Hashimoto thyroiditis. So this we discussed. Let's talk about two main conditions. It's autoimmune thyroid diseases. So that's what we should discuss. Hashimoto thyroiditis, it causes three main mechanisms. We have CD8 positive cytotoxic T cells, which cause direct injury. CD8 positive T cells directly without immediately cause the cytotoxicity of thyroid gland. So somehow, so with the unknown reason, so thyroid epithelium became enemies for this immunity cells, and they start killing. Okay, CD4 positive cells or T helper 1 cells, yeah, they don't act individually, but they produce interferon gamma, which classically activate macrophages, and activated macrophages in this area causes also injury to thyrocytes. And then we have finally we have production of antibodies. It's known as humoral immunity activation, yeah. Plasma cells, so with unknown reason, so gets activated, might be by same CD4 positive cells, or might be from other reason. They cause the production of anti-thyroid antibodies, and anti-thyroid antibodies cause the activation of cascade, which is known as complement system cascade, and it's called the activation of macrophages or NK cells. So with Fc receptor, and then cells of thyroid gland are destroyed. So you see, all this, whatever is the fact, might be all of them three are mixed up, but it leads to decrease of follicular cell activity in the Hashimoto disease. So you see, iodine level is normal. So might be now it's normal, but before, usually, as it was mentioned before, Hashimoto disease is made when we had iodine deficiency, and as well iodine deficiency is there, so less amount of tyrosine and trityranine is produced. So clinical features are understandable. Hyperthyroidism, all effects of hyperthyroidism, so which are and sometimes we see the temperature, increased temperature, so due to autoimmune lesion. So here in diagram you see, so this is normal parenchyma of pretty normal parenchyma of thyroid gland. This is visible, yeah. But here we see the lesion with the tissue lesion, which is with some acts of necrosis. In some places we see inflammatory cells, which are very not well visible here. Okay, but you see, it's just damage to the cells going on. But here I wanna, so different forms you'll discuss in internal diseases, might be more even better to discuss in endocrinology subject. Then we have Graves' disease, which is much more interesting as for me. Graves' disease, it's also autoimmune inflammation, same reason as we discussed before, same features, but it has very interesting one little feature which changed everything. Graves' disease, and unlike Hashimoto disease, in Hashimoto we have hypopituitarism, but in Graves' disease we have hyperpituitarism. Because of what? because in Graves' disease produce very specific antibodies. These antibodies by the structure resemble the TSH, tyrotropin, thyroid stimulation hormone, and their active site in this antigen, this antibody acts against antigen, acts against TSH receptor, and instead of binding and killing this receptor, it causes activation of this receptor, and that's why thyroid gland. So you see antibodies which are produced by plasma cells, they act in the same way as TSH produced by small pituitary gland, and that's why, of course, these antibodies against TSH receptor it causes an overproduction, overstimulation of thyroid gland, overstimulation of follicular cells, and they produce a lot of T3 and T4, and of course it leads to hyperthyroidism. Yeah, also in the same way as it caused by Hashimoto disease, it can cause little bit inflammatory reaction in thyroid gland. Also, it later the same thing will cause the destruction of the cells, and very later, so might be patient won't survive till this. So it leads to hypothyroidism, but usually Graves' disease remains like hyperthyroidism with production of large amount of T3 and T4. So we have pathogenesis like thyroid stimulation immunoglobulin, TSI, it's IgG. Sorry, thyroid growth stimulating immunoglobulins. So it's directed against TSH receptor. Antibodies have been implicated in the proliferation of thyroid follicular epithelium, and TSH binding inhibitor immunoglobulins. So these anti-TSH receptors antibodies prevent TSH from binding to its receptor on thyroid epithelial cells, and in so doing may inhibit thyroid cell function. So it's coexistence of stimulation and inhibition of immunoglobulins in the serum of the same patient is not unusual and may explain why some patients develop episodes of hypothyroidism. So you see, that's what I talked about. So in some cases we don't see only hyperthyroidism, but also sometimes hypothyroidism. So Graves' disease, then goiters, diffuse and multinodular goiter. So what is diffuse goiter? So diffuse goiter is typically endemic goiter. Endemic goiter due to less consumption of iodine. So what's the logic of this? So usually we think, yeah, if we have something less in amount, so it is produced less amount of hormone. So then tissue is decreased. Actually, here we have opposite thing. So you see, this is normal parenchyma of thyroid gland. So you see these nodules which are present here, they're very small. But when iodine is deficient, so it attracts more iodine inside it, and we need to attract more iodine. So for this we increase the mass of this. Да, конечно. Я уже закончу. And then if we have increased mass of the thyroid gland, so we can capture more iodine, even if it's present in a little amount in our blood, so we can capture more iodine in this case. And then these follicles became such a large structures. And here we have thyroglobulin, which waits for its iodine, but iodine is not coming. So that's why we see this picture of goiter. Then we have sporadic goiter. It's less frequently than endemic goiter. So in this case, so it might be caused by excessive ingestion of substances that interfere with steroid hormone synthesis. So braziacea, for example, it's okay. Might be so some special products which are present in some areas, so very rarely used, so which cause a dyshormonogenic goiter, so which decrease the activity of which decrease the formation of T3 and T4. Then neoplasms. Neoplasms are so we have solitary nodules, nodules in very young, already old individuals, nodules in males, more likely to be neoplastic than are those in females. History of radiation can increase the cause of these nodules. Nodules that take up radioactive iodine in imaging studies are more likely to be benign. Okay. So there are adenomas. So adenomas, by the same reason we discussed in pituitary gland, it might be different adenomas which are producing adenomas or non-producing adenomas. Okay, carcinomas are very rarely found in thyroid glands. But if we have them, they are most commonly it's papillary carcinoma. It's in 85 cases of carcinoma they are present. Then follicular carcinoma, much rare, rarely present, 5 to 15% of cases. Then anaplastic carcinoma, less than 5% of cases, and medullary carcinoma. So in these cases, thyroid glands, thyroid hormone secretion is not very common. So because of you remember aplasia due to dysplasia or aplasia of this anaplasia of these tissues, it leads to decrease of decrease of hormone synthesis. So these mechanisms we discussed it in we discuss them in cancer. So exact features of each type of cancer you discuss in endocrine system, endocrinology topic subject in next years. Then let's talk about parathyroid glands, and then we'll finish on it. Parathyroid glands are we discussed parathyroid glands, they produce parathyroid hormone. Parathyroid hormone, and most common disorder here is adenoma, and parathyroid glands, adenoma of parathyroid glands secreting the parathyroid hormone, so causes what? Hypercalcemia syndrome. Hypercalcemia syndrome causing the resorption of bones and increase of calcium level in the blood. It leads to metastatic calcification of different tissues. So all cartilages of the body, so all hyaline cartilage of the body gets calcified in one hand. In other hand, bones became resorbed, so less dense, and it leads to, of course, osteoporosis. This disorder is named as osteoporosis. For kidneys, it also causes effect on kidneys by formation of stones, kidney stones, and which are so coral-like stones, so which causes which requires the surgery. Okay, and usually hyperparathyroidism we have, but we have hypoparathyroidism. Usually it's secondary lesion after the surgery. So when we decrease the parathyroid gland, so after the surgery on thyroid gland. So when during the surgery we cut out the parathyroid glands. Okay, hypoparathyroidism is very uncommon. Here we stop. So thank you for attention. If you have any questions, you can ask me now.